Hello, everyone. My name is Isabella Edwards, and I've had the pleasure of working with NTID's Center on Culture and Language this summer to investigate the possibility of healthcare provider bias based on hearing status. Before I begin my presentation, I would like to spotlight the CCL's Center Director, Dr. Hauser, and my mentor for this project, Dr. Pinko. A big thank you to both of you. Now, the study. Studies have shown that the quality of the patient-provider relationship is more important than the quantity of the information. While it is true that an individual will benefit from more information, it is important that the patient thoroughly understands the information that is given and is comfortable asking any questions that they may have. Unfortunately, the quality of such a relationship may suffer if a patient is identified as deaf or hard of hearing, as the healthcare provider may develop negative emotions. While it is not true for all healthcare providers, some have indicated that the development of such feelings are due to the added time and effort for such patients. Further, many healthcare providers do not allot additional time for deaf or hard of hearing patients, leading to incomplete information being given or unclear instructions. This is especially true for healthcare providers that do not enlist the assistance of trained interpreters. But even if they do, 59.4% of healthcare interpreters say that their patients do not understand the extent of the medical information being given to them during appointments. We can only speculate how much higher that number is for appointments without an interpreter. This may be one of the reasons why 48% of deaf and hard of hearing individuals have inadequate health literacy, but little information could be found that is not from the point of view of the patient. And while this information is vital to understand the limitations of the healthcare industry, we must also seek to understand the view of the healthcare provider so we can eliminate any barriers that may present themselves from their end. This identified issue results in the current study seeking to understand if there is a relationship between how healthcare providers view their patients and their patients' hearing status. There are a few follow-up questions if a relationship appears to exist and is valid. A, could this bias affect the perceived health literacy of the patient? And B, could this bias affect the relationship between healthcare providers and their patients? The population for this analysis is focused on the healthcare providers. 31 female participants filled out the survey, all licensed physicians with an average age of 40 years old. 92% identified as white, and 8% are deaf. While the inclusion of the providers is an important aspect of this demographic, the lack of diversity in sex, race, and hearing status may limit a full understanding of a healthcare provider's perspective. Only 71% of the providers that completed the survey have had or currently have deaf or hard of hearing patients, another factor to keep in mind while analyzing the data. The study itself is a secondary analysis of data provided by mentor Dr. Tiffany Pinko. This original data was a survey aimed at healthcare providers that offered contraceptive counseling, specifically looking at counseling for long-term contraceptives in relation to the deaf community. It is important to clarify that all of these responses are by healthcare providers, not their patients. A chi-square analysis has been deemed suitable for certain questions to determine if the question subject is independent from the patient's hearing status. Descriptive statistics are being used for further analysis beyond this. Due to the background research, it is hypothesized that the healthcare providers would display some level of bias regarding their patients due to the hearing status of the patients. Here are a few example questions from the original survey taken by the healthcare providers. The chi-square analysis will be cross-referencing the responses from the question on the left and the hearing status of that question. There is a congruent question asking about hearing patients. Question on the right is an example of another question found in the original survey. While the chi-square test showed no significant correlation between how receptive patients were seen to be to contraceptive counseling and the patient's hearing status, descriptive statistics showed the possibility of a bias being present. 22.7% of healthcare providers who filled out the survey believed that compared to their hearing peers, they believed their deaf patients are inadequate or delayed in their level of sexual education. And 50% were that there is a lack of understanding or miscommunication between themselves and their deaf patients. These findings indicate that while this particular analysis did not result in significant data, it did provide proper evidence for continued research in this direction as it relates to bias in the healthcare field. For further research, a larger population size should be sought after, specifically a population with more diversity so as to investigate other participant interactions. A survey focused on detecting bias would also be beneficial to this study to specifically target the research question. An implicit association test would be the best method to complete this task. Finally, I would like to thank everyone who completed the survey, all the staff at the CCL, and RIT for giving me this opportunity.